Early in our conversation, we were talking about LDL, how traditional LDL testing, there's no value there. But the small particle LDL, there is value there. Do we know the physiology of that form of LDL, how it's causing cardiovascular disease? Or would you even say that it's causing it? Because there is so much conflicting information in this realm where there's people saying LDL is just an innocent bystander when we have these plaques. There's people saying it's the only cause. That's more conventional thinking. And it sounds like you're somewhere in between. So I'll have you talk about physiology there with the small LDL and what's actually happening.
So recall that the small LDL particle is initiated by consumption of anything that looks like sugar. So glucose, sucrose, fructose, and the amylopectin A of grains. The worst, by the way, is the amylopectin A of grains. So you eat those foods, sugars or grains, your liver converts those sugars to triglycerides packaged in a VLDL particle, a very low density lipoprotein. That VLDL particle interacts with LDL particles, making them triglyceride enriched. And then that triglyceride enriched LDL particle goes through a series of what are called remodeling steps, enzymatic remodeling steps, that creates the small LDL. That small LDL, because it's small, is better able to infiltrate into the walls of arteries. It's more adherent to structural tissues in the arterial wall. That small LDL is also more prone to oxidation, which makes it more dangerous, and to glycation, like we talked about. So it's glycoxidized small LDL particles that infiltrate the walls of arteries. And that small glycoxidized LDL particle is very resistant to liver metabolism. And that's because when an LDL particle is large, as occurs when you eat olive oil or pork, that large LDL has a protein called apoprotein B exposed on its surface. And the liver sees it, clears it promptly within 24 hours. When the particle is small, the conformation, that apoprotein B is partly concealed, and the liver does not recognize it. So that small LDL particle goes around and around and around in your circulation, giving it lots of opportunity to take up residence in your arteries. And so, and once that small LDL particle enters the artery, it's very good at triggering inflammatory responses. And the process of insulin resistance, inflammation, and endotoxemia from SIBO are amplifiers of that entire cascade. And so you can see, now wait a minute, Lipitor and Zocor and all those three, they reduce LDL cholesterol, the marker for heart disease, and they worsen insulin resistance. So we contributed to a study years ago. One of the things we were doing years ago was tracking coronary calcium scores because calcium occupies 20% of total atherosclerotic plaque volume. So you can use calcium as a very convenient dipstick or gauge of how much plaque you have. Well, so we're scanning people left and right and finding hidden heart disease, silent, and people like you and me going to work, riding their bike, that stuff. And someone comes in and says, "Hey, I'm 52 and my dad dropped dead suddenly at 56 of a heart attack. Do I have that in store also?" So we do a CT heart scan to generate a cardiac calcium score. And his score, let's say, is 400, which is a high score. Normal is 0. And we help publish these data. If you do nothing, a score of 400 year later is 500, 25% higher. Year later, 625 or whatever, 25% per year. And every year you're closer to dying, having a heart attack, sudden cardiac death, right? Well, we did this. What if we put you on baby aspirin, a high dose of a cholesterol drug like Lipitor 40 milligrams, cut the fat and saturated fat in your diet, and had you exercise? How fast does that score go up? 25% per year. It has no impact whatsoever on that measure. That's what led me down this path, Jesse, because I started asking, well, if I got people freaking out on me, what can we do? Well, that's where vitamin D, huge effect. Calcium scores did this. Omega-3s, elimination of the small LDL particle via wheat, grain, and sugar avoidance. All those things came from trying to figure out how to put a stop to the progression of heart disease.
For somebody right now that wants to see where they're at on that continuum of heart disease, is the CT scan of the coronary arteries the gold standard to assess?
It is. It has been for about 30 years. When we first started doing this 30 some years ago, we got a lot of skepticism, but the science has become very clear. It is. So if I said your cholesterol is 240, are you going to die of a heart attack tomorrow? In 10 years? You have no idea. It's a lousy predictor. What other gauge is there for your potential for heart attack? Well, the best by far is a coronary calcium score. If your score is zero, your risk for heart attack is virtually zero. I say virtually because this can sound crazy. I can't stop you from using methamphetamine or crack cocaine. People do crazy things, right? But for all practical purposes, score is zero, zero risk for heart attack and other cardiac events. What if your score is 700 and you allow it to go up 25% per year? Your risk is really high. You're virtually guaranteed you die or have a heart attack within 5 to 6 years. What if your score is 700, but you did vitamin D and eliminated wheat and grains and sugars, eliminated small LDL particles, and got omega 3s at a healthy level, got iodine, your thyroid, and address your SIBO, and your score is now 500. So it's a high score still. What's your risk for heart attack or death? Virtually zero. So you don't have to get back down to zero to be safe. You just have to keep it from going up like that, as it does on Lipitor, baby aspirin, and low-fat diet.
And when it comes to that score, is that looking at hard and soft plaque?
So critics who don't understand the science will say things like this. Well, we don't care about hard plaque. We care about soft plaque. Well, calcium is an index of total plaque. My friend John Rumberger, when he was at Mayo Clinic, developed the science behind this. He showed that calcium is an indicator of total plaque in all its elements: soft elements, fibrous elements, calcified or hard elements. So it's a way to track total plaque. I will tell you this though: in the number of years back, I was trying to figure out a way to keep that from happening, make it do this instead. The first time it happened, a guy had a score of like, I think 700, and then he came back and scores like 350. I said, no way, no way. So I went back, put the scans up side by side. We measure calcium because it's easy to see and quantify precisely, down to tenths, even hundredths of a millimeter. But you can still see those soft elements, and you could see that the entire plaque had shrunk dramatically. And so I know we've done this over and over and over again. I published some of those data. You can reduce cardiac calcium scores, and it has nothing to do with reducing cholesterol, has nothing to do with statin cholesterol drugs, has nothing to do with all those things they focus on, but it has to do with things like wheat grain sugar avoidance, vitamin D, all these things you're familiar with, omega-3 fatty acids, iodine, addressing your bowel flora.
All right, so a CT scan of the coronary arteries can detect soft and hard plaque, correct?
Or total plaque. It's an index of total plaque.
Which is just a total of the two together, right?
Like when you check your oil in your engine and it shows you have 1 inch of oil. Do you really have 1 inch of oil? No, you probably have 4 or 5 quarts of oil, right? So calcium is kind of the dipstick for total atherosclerotic plaque.
Okay. Just to get into some nuance here, do you feel like the soft plaque is more dangerous than the hard plaque?
Oh, there's no question. There are conformations, there are shapes of atherosclerotic plaque that are more rupture prone. That's what we're talking about here. So in my cardiology days, one of the things we do is do something called intravascular ultrasound. What that means is you pass an ultrasound probe down into the coronary arteries and you map out its contours. You could see where the calcium was, you could see where the soft elements were, you could see where the cap was, you could see all incredible detail. And so there's no question, softer plaque is more rupture prone than plaque that has calcium in it. But the truth of it is, and this comes from years and years and years of mapping people's arteries out, plaque is a whole bunch of crazy things. And you'll have little calcium here, some fibrous elements here, some inflammatory. It's a whole mixture. It's a hodgepodge of things. And so this notion of we only want soft, the reason they say that is because they're trying to make the argument that even if you have a 30% blockage, that justifies a several $1,000 procedure to implant a stent or bypass your arteries. In other words, they're trying to make the argument they should bypass or stent just about anything, which is nonsense. So that comes from people who push for procedures. That's the blessing and curse here. Procedures are very good now; they're quite refined, but they also pay very well, and that is an incentive a lot of my colleagues cannot resist, and so they'll stent or bypass almost anything. And that means a lot of procedures. It's hard to get a fix on this. There have been some analyses that suggest about 30% of all heart procedures are unnecessary. I think that's probably accurate, maybe a little more than that. But there's a lot of because it pays so well, Jesse. It's just pure. If it didn't pay so well, if you got paid $10 to put a stent in, no one would be putting in stents.
All right, so give me the bottom line on all this. What's the number we're looking for? And it sounds like this number does encompass soft and hard plaque.
Yes. So calcium score is an index of total plaque, and you can reduce that score very easily. But a statin drug will, in fact, there's good evidence, several clinical trials in which statin drugs actually accelerated the accumulation of calcium. My colleagues who apologize for the statin industry will say things, oh, that's proof that you're converting soft plaque to hard plaque. That is not true. There's no such evidence. That's just their speculation to protect the pharma people. Uh, so what we do is we address the real causes. Vitamin D deficiency, liver de novo lipogenesis that creates VLDL and thereby small LDL. Nutrients that, when put together, synergize to minimize insulin resistance and inflammation. And we address bowel flora so that we eradicate endotoxemia that drives. If you have coronary disease, you've got endotoxemia. If you've got a neurodegenerative disorder or a autoimmune condition or irritable bowel syndrome or depression or suicidal impulses or rosacea or psoriasis or restless leg syndrome or fibromyalgia, you have SIBO and endotoxemia, virtually guaranteed. Now, what if the solution, Jesse, was I say, okay, Jesse, we're going to solve this by removing your small intestine surgically? You would say, well, you better be damn confident that's true, Buster. What if the solution was something that looks and smells like yogurt that you make in your kitchen? Well, you don't have to be quite so certain. And what if that same concoction that looks and smells like yogurt also smooths your skin, restores youthful muscle, increases your testosterone by 50% in older guys, restores vaginal moisture in ladies, older ladies, increases libido, preserves bone density, and makes you a better human being because you're more generous, you like people better, you have less social anxiety, and you accept the opinions of other people more readily. We don't have to be quite so certain. And that, by the way, what I'm talking about is making what I call SIBO yogurt. It's a combination of Lactobacillus rhodori, Lactobacillus gasseri. Those two colonize the small intestine, produce bacteriocins. It used to also include Bacillus coagulans for similar reasons, but we did a whole bunch of testing and found that Bacillus coagulans in yogurt is not a reliable fermenting microbe. It requires a very specific environment where you control pH and osmolality and mineral content, which we don't do in yogurt. So we're going to drop the coagulants. I'm contemplating adding a third microbe, but right now, if all you do is ferment Lactobacillus rhodori, Lactobacillus gasseri, microbes you're supposed to have because your mom gave it to you when you passed through the birth canal and breastfed, but likely lost it because you took antibiotics 10 years ago or whatever. You lost it. Now you're going to restore it. And one of the great effects is push back SIBO and reduce or eliminate endotoxemia.
And we've gone into this in great detail if people want to go back and listen or watch our previous conversations. Before we leave this CT scan piece, obviously a score of 0 is what would be ideal. It sounds like we can't always reverse back down to 0. But if we're coming down with our number, it sounds like that's a sign that we're obviously making progress. But if you're somebody that had a score of 500 and you're down to 250 and you're maintaining there, do you feel confident that things are stable at that point?
Yeah. So what you're doing is stabilizing plaque. So heart attack, sudden cardiac death, people think of it as they think, oh, block's getting worse and worse and worse and worse. That's not how heart attacks occur. Heart attacks occur from a minor plaque, maybe only blocks 30% of the diameter, that ruptures like a little volcano. and that triggers blood clot formation. And so that's how heart attacks occur. So when we have a drop in a cardiac calcium score, we're achieving stabilization and reduce the potential for plaque rupture. So when you have a score that's not changing or that's reduced, the heart attack risk is virtually zero. And once again, I say virtually because I can't stop you from taking methamphetamine or crack cocaine.
No, perfect. Important we get into the nuance there. And last piece with cholesterol, the small LDL. Do we know for certain if it's causative when it comes to heart disease? Or does there need to be another insulting factor for it to go to that site of injury and then progress things? Basically, just want to get to the distinction here, whether we think that it's part of the problem once there's already a problem, or is the small particle LDL the actual initiator?
It is the actual initiator. Well, we should say small LDL is a product of carbohydrate consumption magnified by insulin resistance, inflammation, and endotoxemia. So that's why we address all those things. And then when you do that, small LDL typically drops from, say, 2,000 nanomoles per liter to zero. So we're not talking about like, oh, it's 30%, but no, most of the time you've eradicated it. Now, great things happen. So when you look at LDL cholesterol, does it have other things that occur with LDL cholesterol? No. There's nothing else that tracks with LDL cholesterol because it's not a real number. It's a fictitious number. It's obtained by something called the Friedewald calculation. Small LDL, if you have, let's say, 1,800 nanomoles per liter small LDL, what else is evidence that something's wrong? Well, your HDL is low, maybe 32. It's also abnormally small. You have too much VLDL and triglycerides, so high triglycerides. My definition of high, by the way, Jesse, is anything above 60 milligrams per deciliter. The lab says 150, but you now know labs are full of nonsense a lot of time because you can still have a fatal heart attack from that triglyceride level at 130. So we aim for 60 milligrams or less. So small LDL co-occurs with low HDL, small HDL, ineffective protection, more VLDL, higher triglycerides, higher C-reactive protein, higher blood pressure, higher blood sugar, higher hemoglobin A1C. In other words, small LDL doesn't occur in isolation. It occurs as part of a cluster of abnormal effects that magnify cardiovascular risk. LDL cholesterol occurs with nothing. Nothing tracks with, except total cholesterol. But none of those other measures, nothing correlates with LDL cholesterol. So, but it pays well. The LDL cholesterol reducing franchise, statin drugs, PCSK9 drugs, all that stuff, pay huge amounts of money. And just a few years ago, it wasn't uncommon for a farmer to make many tens of billions a year. And so that's because it pays so well, that's where all the attention is focused. Even though you see, the great thing about this, that's the bad news. The good news is you, your family, your listeners have magnificent control over cardiovascular risk. And sadly, the last person to ask is the cardiologist or the general practitioner or the primary care doc. They don't know.
If you enjoyed that clip, you're going to want to head over here and catch a full episode. I'll see you over there.
No, there's nothing else that tracks with LDL cholesterol because it's not a real number. It's a fictitious number. It's obtained by something called the Friedewald calculation. The LDL cholesterol reducing franchise, statin drugs, PCSK9 drugs, all that stuff pay huge amounts.